Welcome back to Beyond Well Science. I'm Sheila Hamilton, and today I am delighted to be on the phone with Dr. Sandra Steingard. Sandra is the board chair of the Foundation for Excellence in Mental Health Care, and as of January 1st, she is the editor-in-chief of the Community Mental Health Journal. Sandra, it is so wonderful to talk with you. Thank you.
Thank you for having me.
I want to first begin by something that I have read in many journals and articles around the kind of movement that you're in, and it's called slow psychiatry. Could you tell me what that means?
Well, it's a term that I borrowed. It's appropriated from the slow food movement, and the analogy is that the slow food movement emerged as a response to industrial agriculture that valued production above all else and didn't pay attention to the impact of industrial agriculture on the environment, on the social meaning of food, the social relationship of food. And what we've developed in that world is an area where we are very good at producing food, but a lot of the food makes people sick. And we've lost the culture of eating, the support for the nurturance, what food means in a culture, and we are devastating our environment through some of the practices that we have. So the way that applies to psychiatry is that we have focused in a very technological way on problems, on how to fix problems, and good outcomes are seen as being very efficient, seeing a lot of people in a short period of time. For instance, in some clinics, psychiatrists will be asked to see, 6 patients in an hour, and that would be considered a good outcome. A high productivity might be considered a good outcome, but we're not paying attention to whether that high productivity really leads to good outcomes in terms of the quality of a person's life, in terms of longer-term outcomes and how a person is doing. So it's sort of calling for a retrenchment and really looking at, in a larger framework, at what is it that we want to do and how we can be most helpful to people.
Immediately what comes up for me is that the insurance companies probably don't like that very much because, they are right now reimbursing people for 15-minute med checks, and that's as much as they want to pay.
Well, one aspect of what I'm suggesting, which isn't always popular among my colleagues, is that I'm not sure all of this work needs to be done by physicians who are highly reimbursed. And I think that there are a lot of interventions that can be helpful for people that aren't at their base medical. So one push behind these 15-minute visits is that there's a perception that there's a shortage of psychiatry. And although I don't know this for sure, I have a hypothesis that part of the perception that there's a shortage of psychiatry has to do with the distorted demand. So, for instance, if one thinks that the medications that we prescribe are highly effective, then you do want to get as many people in to see psychiatrists as possible so they have access to these highly effective treatments. Now, although I think the medications can sometimes be effective, I think they're overall overrated.
Overused, overrated.
So I think if we could sort of right the ship in terms of having a different kind of understanding of how to use the drugs and when to use the drugs, then I think there might be a lower demand on psychiatry, and that might open up room for other people who I think have a lot to offer people that are in different kinds of distress. So it doesn't need to be a psychiatrist. I think the role for doctors in this arena of mental health problems is, in my view, relatively small.
Oh, Dr. Steingard, I love this conversation. Right now in Oregon, for every 15 kids who are in crisis, we have one child psychiatrist. And my ask has been, why can't we have, similar to the PA in a physical health setting, why can't we have psychiatric PAs? Why can't we have a step-down level of care where kids who just really need someone to talk to about the bullying that's happening at school could have that person and not actually need that person who can prescribe them something until much further down their mental health journey.
Yeah, I mean, and that's what I was going to say when you talked about the psych PAs. I mean, we do have those positions in Vermont and elsewhere, and psychiatric nurse practitioners who are, called mid-levels. Mm-hmm. And I certainly think that they have a role, but I'm taking it one step further and saying, yeah, why don't we talk about other things and bullying or trauma or nutrition or, the multitude of things that can go on in a child's life, and to hold the medications in the background. Again, these medications have not been shown to be as effective as is commonly thought. And I worry a lot about. I don't really talk that much about pediatrics and child psychopharmacology because it's not my training, so I really want to be careful. But I have my worries about what I've seen, what I've observed happening in both adult and child psychiatry, which is a tremendous expansion and who falls under the umbrella of being considered a candidate for pharmacotherapy.
Yeah, no kidding. So you've begun practicing this way yourself with your team and patients at Howard Center in Vermont. So talk to me about how it looks, how it might be different from what we currently have in the system that we might be using now.
Well, I sometimes think if someone sat in my office, maybe it wouldn't look that different. But I can tell you a few things that have affected my practice. Now, first of all, I work generally with people who have experienced psychotic conditions. And for the majority of my career, I believed what I think most psychiatrists believe, which is that medications are essential to the treatment of psychosis. Mm-hmm. And I have moved away from that. I also try to hold diagnosis lightly because I think that sometimes by putting a label on someone, you can do damage. And I think you also close down ways of understanding the problem. So where I've shifted in my use of medications is from what a psychiatrist, Joanna Moncrief, has characterized as a disease-centered approach to a drug-centered approach. So this is borrowed from her writing. The common standard way of thinking about psychiatric drugs is to think about them in a disease-centered way, mainly that these are drugs that are targeting and correcting a particular abnormality in the brain that's causing the problem. So the common notions of a chemical imbalance, for instance, like these are drugs that are correcting some kind of chemical imbalance, although that's not really considered state-of-the-art thinking. I think there's still a common kind of thought that when you take these drugs, you're taking them to correct some particular problem.
Right.
In a drug-centered approach, the way you think about these drugs is that they're fundamentally psychoactive substances, and that those psychoactive effects may be helpful for some people at certain times in their life. But it's not because it's correcting some underlying problem. It's really superimposing a psychoactive effect that may be helpful. So when I give talks about this, I say, for instance, that I'm kind of a socially awkward person, and although I'm not a big drinker, that I may, in a cocktail party situation, have a little bit of wine which has the effects on me that it has on anybody. It's a little bit of a euphoriant, it's a little bit disinhibiting, and that effect will get me through, whatever situation I'm in. Now, you could say, I have cocktail party deficit disorder, and the drug is treating that disorder. Or you could say, I have a brain, my brain responds to alcohol the way most brains do, and that in certain situations, that effect is helpful to me. Now, that I think makes sense to a lot of people. In fact, it sounds silly to say I have cocktail party deficit disorder, but you can take that idea and apply it to anything. What do antipsychotic drugs do? These are the drugs that we give to people who are experiencing psychosis. They don't correct the problem. We don't even know really what the problem is. But they have a kind of dampening effect on thought processes that may be really, really helpful to someone who's experiencing voices or having a lot of paranoid ideas. That kind of dampening may give them relief.
Yeah.
But if we continue that drug indefinitely, well, it may alter the brain in a way so that when you stop it, the person may actually be more prone to having these experiences. So we want to think about that when we stop the drug. And that dampening effect may also cause a kind of apathy that may hinder the person's ability to fully recover. And there are now studies that suggest that. So when I offer people these drugs, I talk to them in that way. You're having these problems, and this drug may help you right now. We can try that. Let's see what it does. Let's consider down the road whether it needs to be continued. And that's a very different way of talking about them, as opposed to saying you have schizophrenia and the treatment is to stay on this drug indefinitely.
Yeah, I totally get that.
If we stop it, you're going to get ill again. So that's the kind of thing. When I talk about diagnoses, I never say you have something. I say you're having problems. And our way of talking about it as psychiatrists is to give labels that we apply to certain clusters of experiences. Now, this label may or may not be helpful to you, and the most important thing is that we try to understand what's happening and what your understanding of it is, and I just don't put a lot of weight on the label. But if I use it, and we have to use it for insurance reasons, I talk about in that way a label that we need to use.
Yeah, where you also could put the label shared humanity.
Yeah.
Because being human involves a heck of a lot of suffering, and some people have different brains that interpret that suffering in completely different ways. Sandra, one of the things that I think about, I've gone through an experience as a family member, is that initially I kind of felt some relief at a diagnosis, but in the way that my late husband was treated, he was treated to say, well, this is what we know about this, that you have a much higher rate of suicide, that you have very little capability of continuing in a stressful career, that you should likely give up any kind of responsibilities that tax your brain. And it was such a limiting diagnosis. Now, if he'd been given a diagnosis that was like, okay, you're overweight, and we know you're overweight now, but we think you can do some things to work on that, I think it would have been a completely different experience for him.
Yeah, I mean, one of the premises that I've incorporated in this idea of slow psychiatry and sort of related practices is to kind of hold tightly the notion of humility and to be honest about the many things that we don't know.
Oh, that's cool.
It doesn't need to be a complete devaluing of psychiatry or professionalism, but to just be pretty honest with yourself and the people that you're working with and families that these are really complicated problems and there's much that we don't know. So if someone gets diagnosed with something, to kind of hold a lot of that sort of predictions about the future in a much lighter way, because, I mean, just your experience with your husband to, be given something that's so heavy is not without consequences. That,
Indeed. Which is
experienced.
the loss of hope, and if you're a healer, as you are, and you went into this to heal people, I think that has to be at the centerpiece of what you're attempting to do, is provide some hope for them. So how does this correspond, or I don't know if it does, to the field of critical psychiatry? Is this the same thing?
Critical psychiatry, and I would identify myself as a critical psychiatrist. So the notion of slow psychiatry was a way of talking about some of these ideas. But critical psychiatry encompasses a lot of ideas. I've been highly influenced by Dr. Moncrief, who is the founder of the Critical Psychiatry Network in the United Kingdom. And they're a much more active group. They've done very, very good work in the United Kingdom. And they encompass a lot of ideas. So one idea has to do with a critical reevaluation of the effectiveness of medications. Mm-hmm. As a component of that is looking at the influence of commercial interest on the practice of psychiatry and, quite frankly, all of medicine. So I'm talking specifically about the pharmaceutical industry, but in all of medicine you would need to look at the device industry and how that has, quite honestly, corrupted the database in medicine. So that's one area of interest. But they also look at the influence of social factors. When one takes a very technological view on medicine and psychiatry and looks at identifying the problem within the individual, one can underappreciate the impact of social factors, poverty, immigration, bullying you mentioned earlier, that if you put the problem on the broken brain, that can allow you to ignore other problems that are contributing to the person's overall well-being. So there's people who look at those factors and look at trauma in a broader way, and how that has influenced people. The diagnosis of post-traumatic stress disorder, although it was important in some ways, I think has also done some harm, because it gives the illusion that there's this one way that people respond to trauma, and ignore the fact that humans can respond to trauma in a lot of different ways, and that there are different kinds of traumas, and we seem to be vulnerable in different ways. So those are areas that come under the field of critical psychiatry. And then there's a broader area of what I would call the critical social sciences, that just in general, philosophy, anthropology, sociology, that sort of just take a broader frame of looking at human distress that I think can be very helpful to psychiatric understandings. And in my limited way, I have an interest in that and try to sort of learn about it and help me to broaden my scope of understanding human distress.
Dr. Steingard, since the outcomes for how especially Americans are doing are not going in the right direction, our suicide rate is going up and the rates of expressed depression and anxiety are going way up, do you think that more psychiatrists are becoming interested in perhaps a different way of doing business?
It's hard for me to say, but one thing that I have found since being offered this position of editor-in-chief of the Community Mental Health Journal is that my colleagues have been very positive and supportive. I've been open about my critical perspective, right, both in blogging at Man America. I wrote an inaugural editorial that, lays out some of these ideas, and I've had a lot of positive feedback from psychiatrists that I know and ones I don't know who seem to be very open and receptive to some of these ideas. It may be that they're gaining more traction. It may be that there have been a lot more psychiatrists that have had these concerns than, we have been aware of. I've been really kind of amazed at how receptive colleagues have been to some of these ideas.
Yeah, I can imagine. For people who want to find out more, you can obviously find out more at the Foundation for Excellence in Mental Health Care. The website is mentalhealthexcellence.org, and we're always so grateful to the Foundation for their support of our program. But is there anything that we haven't discussed today, Sandra, that you wanted to?
It's a vast field. I think you did a good job of covering the highlights, and I'm honored to be a part of your program.
And how do people find the journal that you're editing now?
It's the Community Mental Health Journal, and if you Google that, I should know the website, but if you Google that, you will find it. It's published by Springer. And I would also add that I'm on the board of the American Association of Community Psychiatry, and this is the journal of that organization. And just to add, that is an organization that has fully embraced me becoming editor, including the ideas that I've had. So that does reflect an openness to the kind of ideas that I'm talking about today among a number of my colleagues.
Yeah. Dr. Steingard, it was really, really wonderful to talk with you, and so exciting to me. Every time I talk with a psychiatrist who is moving in a direction that feels more holistic to me and more grounded in the true suffering that all human beings experience at some point in their lives, I'm really, really grateful.
Well, thank you.
Yeah. Thanks again, Sandra. To find out more information, head to mentalhealthexcellence.org, or you can click on this link now to become a sustaining member.